Hello, this is Veronica Campbell. I'm teaching the Differential Diagnosis class, and I wanted to give you a little bit more information ahead of time so that you have an understanding of what we're going to be talking about. I find repetition is key in learning. So what I want to explain is a little bit more about how the viscera refer to the musculoskeletal system and why it's important to understand this concept. So first, it's important to understand that the viscera themselves, or the organs, don't experience pain the way we do in our musculoskeletal system. So the organs don't have nerve endings that are pain-related the way we do in the musculoskeletal system. So the information is coming in through other pathways. So we have the vagus nerve, the phrenic nerve, and the sympathetic chain, which comes off levels T1 through L2. And so there's also cervical or celiac ganglion and cardiac plexus and ganglion, and all this communication coming in through all these different nerve pathways into the brain so that the brain and the organs can communicate. So the idea here is that with all this information coming in, there can be some miscommunication. So there's three main theories related to how the viscera refer pain to the musculoskeletal system. One is based off embryology. I'll talk about that more in class. The other two I want to talk about here today are called the multiple segmental innervation pathway, or the shared neurologic pathway. And that one has to do with that T1 through L2. And so when we're looking at T1 through L2, our organs communicate via that sympathetic chain, and they converge on multiple levels. And those levels are also shared with T1 through L2 dermatomes, so the innervation to the skin or sensory input. And so the idea here is all this information is coming in, and the brain can't quite tell where it's coming from, so you start to get some crosstalk. And the areas in the brain that converges has a lot of overlap. So again, there's this confusion in the brain, and so the brain says, well, usually it's the skin that I'm feeling it from, so it must be the skin again, and blames the skin. So then the organ pain can be perceived, or the organ, not necessarily pain, but the organ pathology can be misperceived as something in the skin. The third concept or theory is related to what's called the direct pressure systems and the shared neurologic pathways. And so this one, the idea I think is an example to give you something in your head before I explain it, is the idea of a heart attack. So when we look at a heart attack, we have upper extremity symptoms, we have chest pain, shoulder pain. Did you ever wonder why the heart refers there? So if we look at the pericardial sac, and we look at the mediastinum that houses the sides of the heart, that's innervated by the phrenic nerve. So the phrenic nerve innervates that, as well as the lung pleura. It innervates the diaphragm for breathing. It innervates the upper peritoneum sensory. It innervates some sensory into the liver and the gallbladder. And all these shared pathways with ganglion and plexus as well, with the vagus and the sympathetic chain. So there's all this communication happening. So when the phrenic nerve gets irritated, it has input coming into the brain. But what levels does it come in at? It comes in at C3, C4, and C5. C5 is the more interesting level. That level shares with the rotator cuff innervation. It shares with the rhomboids and the levator and the pecs and the deltoid and the median and the radial nerve. So all this neurologic input coming in from the viscera, sharing this pathway, the brain says, well, usually it's something in the musculoskeletal system. I bumped myself, something aches. That must be where the pain signal or that information is coming from, and so it blames that area. So if we take that concept then and then look at the viscera, anything that comes in contact with the diaphragm can refer through the phrenic nerve. And we have a right and a left phrenic nerve. So we look at the liver and the stomach, the spleen, we have the adrenal and kidneys, the pancreas, all those directly contact the diaphragm. And then if it innervates the upper peritoneum, any inflammation, swelling, or tumors in that area can trigger that input through the phrenic nerve and then be miscommunicated. So when we look at that, quite often we see things like GERD or ulcers will refer to the left shoulder because the stomach's on that left side, affecting that left phrenic nerve. Or the liver and gallbladder will refer to the right shoulder because of the right phrenic nerve. And so then we start to understand how maybe underlying pathologies could create this shoulder pain. And so if our client or patient's coming to us and they say, I have shoulder pain or scapular pain, how do you know where that's coming from? So that's what I'm hoping to start to get you to understand the concepts, and we're going to go into more depth in class, is how we'll have some tools and labs and palpation and different things and how to recognize these symptoms, not teach you how to diagnose, but how to recognize symptoms and know whether or not you should proceed and continue to treat or see that client, or maybe you need to refer them back. So we'll be going into much more in depth with this, but at least you have some ideas and concepts that are going to help make that first lab go better, and hopefully the whole class make more sense to you. If you have any questions regarding this, please feel free to reach out. Otherwise, I look forward to seeing you soon.